Okay, all right. So while the slides are loading, so I'm based at the University of Toronto. I lead the AI for Mental Health program there. I'm also the National Mental Health Community of Practice lead within the Temerity Center for AI in Medicine, which is based at the University of Toronto. It brings together all the universities across the country. My focus within that is mental health. So I've been interested in this domain for many years. I'm a psychiatrist, a clinician scientist, and my interest has been principally because a lot of the developments in AI have been based upon how the human brain works. Deep learning is cortical representation to start off. Reinforcement learning is subcortical, and 1/3 of my program is around reverse engineering these systems. I won't be going into that today. Most of my program, 2/3 of my program, is around automating workflows in the clinical context in mental health. So that's what I'll be speaking about today. You'll see as I present that our usual paradigm is we identify a workflow that we're interested in, where it may be possible to automate. We develop the automations, either a single agent or a multi-agent system. And with a bot playing the role of the end user, we essentially show with a sandbox environment and simulations that it actually works well. And then what may be different from some of the talks and presentations you've seen today, I'm a clinician, I'm a clinical trialist, I run a lot of clinical trials. I want to see if these things which in the virtual environments or simulation setup seems to work, does it really work in actual clinical care? So that's what I do quite a bit. I run clinical trials across disciplines, depression, PTSD, anxiety, on the prevention side as well, and more recently in mental health and Alzheimer's as well. Yeah, there you go. So, so I've already introduced myself. So those are my disclosure slides. So everything I present today, I'll be giving a big picture view. I won't be getting into the details. It's all published, or it's in the public domain, or it's actually coming out in the next 2 or 3 weeks. This is my disclosure slide. So I'll give 1 or 2 examples. I've already given the preface as to what we do. We show that these single or multi-agent systems work in a simulation environment, and then we do clinical trials, 2 to 3 year clinical trials. So I'll give examples in each of these contexts. I've already mentioned this as my real interest in the domain. 1/3 of my program is around the interpretability side. I won't be getting into any of those details today. This has been my inspiration to be in this domain for many years now. All my presentation today will be 1 or 2 examples along where we have automated workflows. So I don't need to go through this for this crowd, but I'm just presenting this that about 3 or 4 years ago, as we started realizing that we are moving into an autonomy range, going from various levels of autonomy, we started to think, what would this mean in clinical care in mental health? So if there's one slide to take home from the presentation today, and this will be my cornerstone, and I'll keep bringing this up a couple of times. So this was 3, 4 years ago, us trying to conceptualize what could be the role of these agents in a human-in-the-loop model in mental health. So we came up with this idea of collaborative, assistive, semi-autonomous agents, and then trying to see what the role of the human in that loop would be. This is another way to look at it. What could be some assistive capabilities, some collaborative ones, and then some semi-autonomous ones. I think the one example of generative AI which most clinicians identify with and is in use is the AI scribe. The previous speaker was also mentioning this. A lot of the others actually require quite a bit of evidence. So I'm not going to go into the examples with each of them, but I'll give you 1 or 2 to give you a flavor in all of these 4 domains. So clinical care, so this is us automating my day-to-day clinic with different intake agents. with either a single agent or a multiple agent right through the clinical workflow from when we start seeing the patient to when we discharge them. We have published on each of them, and we are now actually working towards clinical trials. This is the, oops, I just want to go back. So this is the front end and the back end of the clinic. We run clinical trials because it's not important, it's not enough if at that particular workflow the agent is non-inferior to the human doing the task. There are a lot of other ecosystem changes. There's change management, there's service redesign, a number of other things need to happen. So that's where we do mixed methods to see what does it take, even if it's efficacious, for this tool to actually be adopted. We also include cost benefit because that's also a critical factor. So I'll give you two examples here. This is on the clinical side. So we know in mental health that measurement-based care makes a difference. So this is the equivalent of blood sugar for diabetes or your blood pressure for hypertension. Clinicians do scales, or patients do scales, like the PHQ or the GAD-7. For over 2 decades, it's been really difficult to get these things done. So we essentially automated taking unstructured data, so think of your ambient scribe in some sense, and the next step to that, to actually generate the scales, and also prompting clinicians if they have not collected this information. This is moving into trials through Epic at our hospital sites. This is a multi-agent system to do diagnostic interviewing. So essentially, we took the DSM, the operationalized DSM, which is the SCID, and you see a multi-agent system there, one which is asking the questions, another which is overseeing it, does not allow you to move on to the next module, and then which follows the skip logic within the SCID, and then you have an orchestrator/diagnoser. And we have shown that with a bot playing the role of the patient with all kinds of DSM complicated diagnosis, this actually does quite well. And it's now in clinical trials where we're showing where we would like to see if this is useful or not. In the clinical trials, we are purposefully positioning this from mild to moderate symptoms. We know that the person with severe psychosis or depression or Alzheimer's is not going to be able to use this. So I'll move on to education. I think everyone is worried about de-skilling, that people are going to use GPT and not learn what they need to know. That's a legitimate concern and needs to be addressed in different ways. What we have tried to do is, it takes 10 years to train a clinician, 4 years of medical school, 4 to 6 years of residency training. Can we accelerate people gaining competencies through use of agentic AI? So essentially, we broke down the competencies that people are supposed to attain by the time they finish their training. And we looked at each competency, both in Canada and in the US, the respective boards. And we came up with a multi-agent system here. So we have a bot playing the role of a patient. We have a bot playing the role of the clinician. And with the bot playing the role of the resident, who would want to learn skills of interviewing. How does a resident, or a medical student for that matter, learn how to do clinical interviewing, which is the core skill of a clinician, by doing this repeatedly and presenting to the clinician and getting feedback. So essentially, we simulated the whole thing with a multi-agent system, and we are working to have 7 of the largest clinical training programs deploy this. One arm will do the training as they're doing now, and the other arm will see if this, augmented by what they're doing now, would lead to people gaining their competencies sooner, i.e., rather than taking 5 years to finish your training, could you gain competencies in 3 or 4? In theory, this sounds, at least if you look at the system we have built, it sounds to work well, but I come as a clinical trialist from a skeptical perspective on these things, that most of these things are not going to work, at least in the way we think it would work. But the few things which would work will have a transformative effect. So this is another variant of that, a multi-agent system to help residents learn basic principles of psychotherapy. So cognitive behavioral therapy, motivational interviewing, and you have the system. It is like you're interviewing a patient within that framework. So I'll move on. I'm not going to dwell on this, but I've been, over the last 5-10 years, doing a lot of systematic reviews and meta-analysis. I think I won't be doing it in a couple of years. We will have living systematic reviews and meta-analysis with the way things are progressing. What we've been trying to do is not end-to-end automation, but look at specific points within the systematic review and meta-analysis pipeline and what its role is. It takes hours and often weeks for my research assistants to just go through and compare where the errors are as they pull through publication. So this is one paper on the quantitative side. We did the same on the qualitative side, where we do thematic analysis, and we compare the themes which would come through qualitative analysis along with, as compared to the one with generative AI. And we're building in some automations into this. But the bottom line is not end-to-end, still human in the loop. And this was with the previous versions of GPT, but I don't think it's more different with the current versions either. But basically what we're showing is that up to a certain level of complexity and within particular points within the workflow, you are able to automate them. This is the same with another domain, which is in terms of data processing for EEG analysis. So quality improvement, this is my last example within this realm, so this was during the pandemic. Clinicians started doing assessments virtually, and we wanted to know what's the nature of the relationship between the patient and the physician in the virtual settings. We've gone from seeing people in person to virtually. So essentially, this was multimodal. We used different data streams, using unstructured data to produce the working alliance inventory. The working alliance inventory is the proxy for the nature of the relationship between the patient and the physician. So this is gradually being moved into clinical trials. So I'll go back to this, situating this in my presentation again. I've given a few examples along this Agentic AI roadmap where we're actually developing assistive agents, collaborative agents, and semi-autonomous agents. I have 2 more slides, and then I'll end. We've been also looking at various different components of these agents being able to deliver therapy. So these papers are published. And what we see is that as the level of complexity increases, so we essentially forced the agent to be able to do motivational interviewing, and after a certain level of complexity, it is not able to perform. It loses its guardrails. This will be my penultimate slide. So here, we've been looking at if these systems are to independently deliver therapy, what is the nature of the interaction, and what is the importance of the value system within it? So here we looked at low safety guardrails versus high safety guardrails, and we were able to show that the safety guardrails has a significant impact in terms of how the agent is actually perceived. So this is my last slide. So we looked at what the world is doing in this domain. And it's quite important to note that in spite of all the possibilities for what these agents could do, there's only one randomized controlled trial, now coming to 2 with the Therabot last year with Gen AI-based tools. There's a real critical need to have clinical trials, and that's what my team is significantly involved in doing. Thank you.